The next segment of today's proceedings is nothing short of inspirational and remarkable. Out of more than 70 submissions of published researchers, 3 researchers with clinical significance have been selected. These 3 researchers will be presented today at this conference in the Rapid Fire Research segment up next. This session will be chaired by Dr. Lilanti Subasinghe, Consultant Intensivist at University Hospital KDU and Joint Secretary of the Ceylon College of Physicians, along with Dr. Praveen Veeratunga, Consultant Physician, Senior Lecturer at Department of Medicine, University of Colombo and Joint Secretary of the Ceylon College of Physicians. I now invite Dr. Subasinghe and Dr. Veeratunga onto the stage. Thank you.
Thank you. We'll start this session off now. So it's an extremely important session and highlights Sri Lankan researchers and Sri Lankan research, which I think is extremely important. So we start off with the first presentation, which is titled A Real-World Study of the BBIBP COVID Vaccine Effectiveness in a Sri Lanka Rural Province. And the presenting author is Dr. Lanka Wijekoon. So can we have Dr. Wijekoon, please?
Thank you, Dr. Praveen. Good afternoon, all. So I'm Lanka Wijekoon from Rajarata University of Sri Lanka. So today I'm going to share you with an interesting research that we did in North Central Province during the COVID era, particularly during the third wave of the COVID infection. We studied an effectiveness of a COVID-19 vaccine. In fact, we studied the BBIP-COVID vaccine, which is commonly known as Sinopharm. So this was done in the North Central Province, a rural setting in Sri Lanka. We published this original research article with collaboration of international team of researchers last year in a Cell Press journal, Helion. So into the background and rationale. During Sri Lanka's third COVID-19 wave, the Delta variant was the predominant and responsible for the vast majority of deaths, over 16,000 deaths, which accounted for 96% of all deaths in Sri Lanka. Despite supply chain issues, Sinopharm, a dead vaccine, was the predominant vaccine administered through the country. We wanted to investigate the real-world effectiveness of COVID-19 vaccination in the local setting. However, despite high vaccine coverage, there were limited effectiveness data available throughout the low to middle income countries like ours. Sinopharm was the most widely used vaccine, necessitating this evaluation to guide the local vaccine policy. So this graph illustrates the impact of vaccination of COVID-19 during the third wave. The x-axis represents the time in weeks during the third wave, while the blue columns represents weekly new cases within the third wave, and the orange columns represents the weekly new deaths within this period. You can see there are clearly 2 peaks during the third wave of the infection, and during the second peak, which is the worst peak of the era, the case fatality rate reached 6.35%. Sri Lanka began rolling off the Sinopharm vaccine in the May of 2021, and it accelerated its phase with the first dose of vaccination with Sinopharm during the second peak in June. So this vaccine drive was closely followed up after 28 days with the second dose of vaccination. So you can clearly see with this vaccine drive, the weekly cases and weekly deaths and the case fatality all dropped. So there's a clear link between this vaccine drive and the drop of these. However, this could have been due to other causes as well. It could have been due to other vaccines, could have been due to development of herd immunity, also due to government policies like social distancing. Our objective was to assess how well 2 doses of BBIP vaccine, Sinopharm vaccine, protected against COVID-19 infection. Not only that, we also wanted to evaluate how it reduced the hospitalization, severe illness, and death in a real-world setting in a rural province. In our study, severe disease was defined as needing supplemental oxygen, admission to a high dependency or intensive care unit. So we implemented a WHO recommended test negative case control design, which is ideal in a pandemic setting. We included all individuals above 18 years old who were tested for PCR COVID during the study period within the North Central province. And we excluded subjects who had received other than Sinopharm vaccine as for their COVID vaccination. So the COVID PCR positive patients were recruited as cases, while the negative patients were recruited as controls. Our setting was within the North Central province, and we specifically looked into the third wave starting from May 2021 to February next year. So we collected the clinical data from phone interviews with the participants, and we collected the data on vaccination, when they were given, what doses were given, from the National Vaccine Registry. So we screened more than 16,000 PCR case reports, both from the community and from the hospitals within the North Central province within that third wave. And we recruited 6,723 participants. We had more than 3,000 cases and more than 3,000 controls to increase the statistical power of our study. So we calculated the unadjusted vaccine effectiveness as 1 minus odds ratio of COVID-19 infection between vaccinated and unvaccinated groups. And then we adjusted this vaccine effectiveness for other confounding factors, namely age, sex, calendar week of the presentation, and comorbidities and smoking habits of the research participants, using a logistic regression model. Coming to the results, our study proved that 2 doses of Sinopharm vaccine was 30.8% effective in reducing the risk of contracting COVID-19 disease. While effectiveness against infection was moderate, the vaccine showed protection, strong protection against severe outcomes, including nearly 90% effectiveness in preventing severe disease and death. And not only that, it also reduced the hospitalization by 70%. We also studied the effectiveness of partial vaccination, a single dose of BBIP vaccine. The results show full vaccination was superior to the partial vaccination in preventing severe outcomes. In those aged 60 and above, vaccine performance remained high, especially in reducing severe outcomes and mortality, supporting its use in older population. And also we observed that there's a persistent protection for up to 4 months after the second dose, especially for the hospitalization, severe disease, and mortality. So you can clearly see the vaccine effectiveness remained up to 4 months for these severe outcomes. We hypothesized that the persistent protection was due to the long-lasting effect of the T-cell mediated response after dead whole vaccine. These findings align with the international data. Sinopharm may not have prevented all infections. However, it was highly effective at preventing the worst outcomes, likely due to its broad immune response, particularly the T-cell response. Strengths of our study includes our rigorous data collection and real-world setting. Limitation includes potential recall bias of the participants, and also we excluded some of the positive cases, particularly from the lateral flow positives. Nonetheless, the findings were robust. In a summary, 2 doses of Sinopharm vaccine offer strong and sustained protection against hospitalization, severe disease, and death. findings that are strongly supports its continued deployment in a similar setting in future epidemics. I would like to thank my research supervisor, Professor Badrin sir, and my research team and Rajaratnam University. I would like to thank the funding agency and the college and the IDF committee. Thank you.
Thank you, Dr. Vijayakumar, for keeping up to the time and interesting findings. Next up for presentation is a prospective cohort study on comprehensive diagnostic testing identifies diverse etiologies of acute febrile illness among hospitalized children and adults in Sri Lanka. The presenting author is Professor Champika Bodhinayaka. I invite Professor Champika on stage presentation.
A very good evening and thank you, chairpersons. May I simplify the title a bit, because what we are really talking about is diagnostics using gold standards to diagnose acute fevers in adults and children hospitalized in Sri Lanka. We think that we know the etiologies, but we may not be always correct. So the paper was published in BMJ Public Health in 2023 July. There are so many definitions for acute febrile illness, but the commonly used definition is recorded fever more than 38 degrees at presentation or within 48 hours of hospital admission with no localizing symptoms and signs, meaning it is not focally localizing, it's not a pneumonia, not a UTI, not a cellulitis, but just undifferentiated fever. And it's a very common cause of hospital admission, and not only with us, but in many hospital settings. So we have so many research questions as a clinician. What are the etiological diagnoses of these undifferentiated fever admitted to hospitals in large numbers? We don't know. Cause is inapparent. Are they viral or bacterial? So what are the organisms? Does the etiologies differ in adults and children? Are there any differentiating features that we could be using to clinical differentiate or diagnose these illnesses? Is our diagnosis accurate even at discharge? We don't know. And if the diagnoses are missed, how are we going to do better in the future? So these are our questions. And we did this research with Duke Ruhuna collaboration, which is a collaboration since 2006, and Duke Global Health, which helped us in investigations. So this is a large cohort of patients. We had 1,000 patients in our cohort over 1 year, consecutively recruited, consecutive sampling. Majority were adults, 2/3 were adults, and 1/3 were children, admitted to Teaching Hospital Galle, now known as National Hospital. We were able to collect all the clinical epidemiological data and also an acute and a convalescent sample, which is the most important thing in this research. We were able to collect an acute sample and a convalescent sample in 90% of the patients that we recruited, so that we could do some decent testing. And this is our testing algorithm. There were about 45,000 patients admitted to the hospital during that period, and there were around 8,000 patients with fever. And among those fevers, there were eligible people over 1,000. So among those 1,000, we could recruit nearly 75%. So as I told you, we excluded all the bacterial infections and recruited accordingly. So this is our testing algorithm. We can't test all 1,000 patients with all these comprehensive testing. So therefore, we used a very cost-cutting strategy. That is, we first screened them for dengue. And also we did test them for viruses first. So this is our testing algorithm. And all the people who are dengue negative, we tested for other etiologies. So confirmation of the dengue is one test is not enough, so this is a gold standard testing. So therefore, we first of all, as we know, we did IgG ELISA, den virus isolation, real-time PCR for den virus, and flaviviruses were tested for dengue. All of us know that. And upper respiratory pathogens were tested using the nasopharyngeal samples using a Luminex platform, which detected 19 viruses, influenza A, influenza B, the subtypes of A, and parainfluenza, metapneumovirus, adenovirus, rhinovirus, enterovirus, and coronavirus types, some types. This was before the coronavirus epidemic. Otherwise, these all results would have been an entirely changed result that I'll be presenting today. And also 3 bacteria were tested, like chlamydia, legionella, and mycoplasma. Atypical bacteria also was tested in the platform. Then the people who are dengue negative were tested for leptospirosis using IgG ELISA, and if positive, we tested the acute sera by separate IgG and IgM ELISA kits, and MAT with 20 strains, and PCR. Testing was a little complicated, so I will not go into detail. Then the typhus etiologies, rickettsial etiologies, spotted fever groups and typhus groups were tested using IgG antibodies, IFA antibodies. Then we did convalescent samples. If the IgG positive, we treated it to the endpoint, and then 2 pan-rickettsial PCR assays also were run. Similarly, sub-scrub typhus and Q fever were diagnosed by serology, confirmed by serology. So let me tell you the results. We were able to identify an etiology in 2/3 of patients. Majority had an etiology, only 1/3 remained undiagnosed. A viral etiology was found in the majority, about more than 50%. Adults were more likely than children to have a bacterial infection, and the respiratory viruses were identified in younger patients with a median age of 14. The leptospirus and rickettsia were found in older patients. And these are the febrile etiologies. You can see 50% of them are either dengue or respiratory viruses, but we had a fair number of rickettsiosis, about 79 patients with rickettsia, and leptospira 158 patients, and there were co-infections with rickettsia and leptospirosis, and also dengue and influenza. So there were co-infections as well, and there were only 1/3 unidentified. And these are the bacterial etiologies and viral etiologies separated separately. So we had a large number of scrub typhus. 53 patients had scrub typhus and spotted fever group, and also 5 of them had Q fever. So let's see whether there were any diagnostic kind of clinical clues. As we know, joint pain, muscle pain, arthralgia, myalgia, dysuria, conjunctival injection, all those things were present to identify leptospirosis, and also exposure in standing mud, conjunctival injection, jaundice, those were positively associated, but still, after with all those clinical clues available, only the diagnostic sensitivity of clinical diagnosis was 40%. So out of 10 patients with leptospirosis, 6 were missed. But it was actually clinical diagnosis was much better than IgM alone in an acute setting. So how did we do for rickettsia? The rickettsial infection was being a female or housebound, late presentation than the other fevers. Rickettsial fevers presented later than the other fevers, like 5 or 6 days the median duration of fever, whereas in contrast 2 to 3 days in other acute fever. So they presented late. If you have a late presenter, think about rickettsial infection. And only 10% had an SCHA because it is a painless ulcer. And there were no discriminating laboratory findings to identify rickettsial infection. So sensitivity of the clinical diagnosis was very low. It's only 1 in 10 you would find in rickettsia. So these are the sensitivity of diagnosis. Again, we did well with dengue, about 60%, still we missed. Respiratory viruses about 50%. So these are the rest as I mentioned. And children versus adults, actually the viruses were much more common in children. So antibiotic use, we used a lot of antibiotics. In nearly 50% of them had viral infections. 40% of dengue people had antibiotics. Among the patients with bacterial infection, they did not receive antibiotics. Only 2/3 received antibiotics. And 62% only received antibiotics for leptospirosis, and only half of the people with rickettsial infection received antibiotics. So it was a misuse, actually inappropriate use. So in conclusion, ladies and gentlemen, a definitive etiology can be identified in acute febrile illness when using gold standard testing, which is not feasible in a clinical setting. It is not possible to do it. This took years actually for us to complete. So if we are to minimize the antibiotic misuse, new tools need to be developed to bridge the gap between the poor clinical diagnosis sensitivity and the real diagnosis. So what other countries do, like like this, they use acute febrile illness algorithms using point of care testing and biomarkers and as the clinical features overlap, and they integrate the EPID data, clinical data and point of care testing to predict viral, bacterial and the possibilities. So way forward, we need real-time regional disease surveillance data, which will increase our diagnostic sensitivity. We really need regional surveillance data. And also some disease-specific clinical and laboratory identifiers and some low-cost POC, point-of-care testing. Both of the above can be incorporated into clinical decision-making algorithms for improved diagnosis, because we have to have some algorithm to test. We can't test everyone. And electronic tools will really simplify the algorithms. I thank all the patients who participated and my co-authors, and thank you for patient listening.
Thank you, Professor Bodhinayak, for that eye-opening data, and congratulations on your work. Could I have the next presentation, please? So the title is Capillary Lactate as a Prognostic Marker in Sepsis, Correlation with Venous Lactate and Prediction of Outcomes. The paper will be presented by Dr. Philip Anaphalan. Over to you, Dr. Anaphalan.
Good afternoon, all of you. First of all, I would thank CCP and the Infectious Disease Conference Committee for giving this valuable opportunity to present this research article in this prestigious forum. Without further delay, I will move on with my research article, which we have published in 2025. The topic is significance of capillary lactate as a marker of poor outcome in sepsis. These are the content of my talk today. I will briefly touch the lactate in sepsis. Second, I will go ahead with why the lactate is important in sepsis, followed by methodology and the important results finding. Finally, conclude with the conclusions and acknowledgement. As you all know, sepsis is the life-threatening organ dysfunction which caused by dysregulated host response to the infection. It's a major burden on the healthcare system. Approximately around 85% of sepsis cases and sepsis-related deaths occurs mainly in low and middle income countries where the facilities and equipments are lacking. Moving on to the lactate in sepsis, according to the last sepsis guideline, the early identification and goal-directed resuscitation results in significant reduction in mortality in septic patients. It's clearly explained the necessity of laboratory markers in addition to the clinical parameters to guide therapy. The currently available, most available clinical parameters to predict the outcome in critically ill patients are lactate levels and lactate clearance. Next, we will look why the lactate is important in sepsis. I hope most of us are aware about this image. It's published in the Surviving Sepsis campaign. And it is the initial resuscitation chart for 1 hour bundle, where they have given the priorities for the lactate. In the first step, they have mentioned measurable lactate level in each sepsis management. That is why the third international consensus of definition of sepsis and septic shock include the lactate. Move on to the research, why we have focused on this topic. So our main objectives to describe the correlation of capillary lactate and venous lactate measured by the handheld analyzer, to identify the best cutoff value of capillary lactate that predict the poor outcome in sepsis, and third one, to describe the association with the capillary lactate normalization or clearance in 6 hours following admissions and look the outcome in sepsis. The lactate level can be able to measure in several ways: arterial, venous, or it may be a capillary. In the current world, the most commonly usable lactate measurement, as we all know, is the venous lactate measurement. However, in the recent past, In the developed countries, the capillary lactate measurement is getting popularity over the other modalities, obviously because of its facilities, like it's a very quick and less painful and it's very cheap options. In the other hand, the availability of the venous gas analyzer, it's limited mainly in the middle and low income countries where the prevalence of sepsis is high. Let me explain the methodology briefly. Our study was conducted in Colombo South Teaching Hospital Professorial Unit over 6-month duration. We recruit all patients over 18 years, whoever fulfilling the QSOFA criteria more than or equal to with the evidence of infection. Our exclusion criteria expand to the patients having alternative diagnosis for increased lactate level, such as fits and overnebulizations and shocks not due to the sepsis and the dengue shock syndrome, and the patient whoever managed in the peripheral centers and have received the initial resuscitation and transferred to the peripheral cares. We have used Novo handheld point of care lactate analyzer. It measures the capillary lactate and venous lactate level at T0 and T6, that means on the time of arrival and after 6 hours from the admission. Further, we have done a pilot study on this Novo lactate analyzer to confirm its accuracy and calibration as per the ethical protocol. Each and every patient reviewed in 28 days to assess the outcome. Move on to the results. We had received total number of 102 patients. 51% of the study population is females, and the median age group was documented as 71.5 years. The most common cause for the infection has identified was community acquired pneumonia, which has carrying around 33%, whereas the second and third most common documented as aspiration pneumonia and urosepsis. The table listed in the top left corner explain like 14.7% of our study populations received ICU and HDU care, whereas 32 patients required vasopressor therapy. At the same time, the mortality at 28 days documented as in our study was 33.3%. I would like you all to look at this scatter plot graph, at the same time the table. It's clearly explained the correlation between this capillary and venous lactate value with the R squared value of 0.9. Moving forward to the receive operator characteristic curve, where we can see the area under the curve is 0.8 with a variation of 0.72 to 0.91, where we found out the best cutoff value of capillary lactate at T0 predicting 28-day mortality was 3.5 with a sensitivity of 85% and the specificity of 78%. These two tables clearly explain whoever admitted with a capillary lactate value of more than or equal 3.5 at the time of admissions, highly associated with ICU admissions. At the same time, they require vasopressor therapy as well. Further, our study has explained whoever have this high capillary lactate level at the T0 had long hospital stay as well. The final results, it's mentioned here in the two tables, which clearly explain inadequate capillary lactate clearance or normalization at 6 hours time following admissions associated with high mortality and increased vasopressor requirement. These are my conclusion. The first one, the capillary lactate measured by handheld lactate meter will correlate with the venous lactate. Second, the utility of capillary lactate is more practical and is most cost effective and is very patient friendly option for the lactate management in sepsis, especially in a resource limited setup. As we have seen already, capillary lactate value more than or equal to 3.5 on admissions, and the absence of capillary lactate clearance at 6 hours predict poor outcome in sepsis. It associated with higher mortality in 28 days, at the same time increased necessity of vasopressors and the high ICU admissions. It suggests that capillary lactate can effectively aid in early risk stratification. In a nutshell, the capillary lactate detected by the handheld lactate meter is a useful adjunct in the management of sepsis. We have some limitation in our study. So we have conducted the studies 6 months duration, but we have only collected around 102 patients. The sample was relatively small, and we have only covered this study in the ward setup. But this study has been conducted in a tertiary care hospital for the period of months. So the results can be generalized to the large degree. I'm extremely grateful for CCP and Sri Lankan College of Internal Medicine for the research grant in 2022. And my sincere thanks to Professor Junil Colombo South Teaching Hospital and the Chemical Pathology Unit as well for their immense support to conduct this research fruitfully. Thank you for your attention.
Thank you, Dr. Philip, for that interesting lecture and the findings, the research findings. So it's time to appreciate. I'm sure that you all are having questions with regard to the studies, and you can meet the presenters during the tea time and get your queries cleared. It's time to appreciate all of your hard work